Base of the skull fracture causes application of force to skull specifically to the base actually. Directly example an oblique blow of great force applied to one side of the back of the head may start a fracture in the underlying posterior fossa. It may cross the midline to enter the middle fossa of the opposite side, may advance further, may end in the anterior fossa. Indirectly through the face above and the spinal column below, when caused by transmitted force through space, face, or spine. They are usually isolated. A force of a blow on the mandible an uppercut in boxing may transmit it to the maxilla and its internal angular process to the base of the skull may cause an isolated fracture of the cerebriform plate of the thymoid. Blows on the chin occasionally fracture the mandibular force. Application of force to skull anywhere due to general deformation of the skull. A fall on the back of the skull or the head or blow on the top of the head usually produces independent fractures of orbital roof. Independent fractures of the orbital roof. Especially in older people, sudden violent increase in internal pressure produces fractures of the roof of the orbit, especially in suicidal gunshot wound of the skull, causes by sudden release of gas in the skull, extension of fracture from vault. Influencing factors of fracture patterns are strongly influenced by a Petrus buttress. Fracture line approach this buttress from a middle or posterior cranial fossa are either turned towards its apex or base according to the angle at which the strike the middle of the body of the petrous bone is fractured only when the force is great, characterized by most basal fractures need to meet at and overrun the pituitary fossa. The fracture line opens into the basal foramina. Sphenoid fissure is most commonly involved, but the foramen magnum is not spared. Despite its thick margins, longitudinally or transversely directed force will generally produce fractures in the corresponding axis. Types: incomplete fracture do not transverse entire base. Complete or hinge fracture transverse base, creating a hinge divided further into three categories. A. Run in the coronal plane extending from the lateral end of the petrous ridge through the sella thoracica to the lateral end of the contralateral petrous ridge, motorcyclic fracture, most common type of hinge fracture. Due to impact on the side of the head, less commonly due to impact on the tip of the chin indicated by chin lacerations. Less commonly to mandibular fracture. Type 2 run front to the contralateral back. Contralateral plane but do not pass through the sella thoracica. Type 2 run from front of the front to the contralateral back. Pass through the sella thoracica. Type 3 from side to side in the coronal plane but do not pass through the sella thoracica. The water test can be done. Water test can be done as a simple and effectively a way to demonstrate a type of 1 hinge fracture should be present because it connects the internal acoustic meatus on both sides. If it drips out from the nostrils also, fracture of anterior cranial fossa involving cerebriform plate is also established. It is an important and useful test made prior to dissection, so one knows what to expect on opening in the skull. The skull may be opened more carefully in order to extend the fracture. The sign is most useful if an autopsy is not be considered. For religious or other reasons, radiological facilities are not available. Complication: bleeding, fracture of anterior cranial fossa may involve frontal, ethmoidal, or sphenoidal air sinuses, which loss of blood from nose and mouth communicating with the mouth, bleeding and CSF from both. If communicates with the ear, fracture of petrous temporal bone, bleeding and CSF from ear may enter the eustachian tuber, blood and CSF may be swallowed. Tear of posterior branch of middle meningeal artery, severe bleeding from ear. Fracture of the sella turcica. Direct communication between cranial cavity and airway is established. Blood passes in bronchial tree, foci of inhaled blood in lungs. Such a foci are evidence that death do not occur instantaneously. Around the eyes, raccoon eyes, mastered battle sign, cranial pneumatocoele, if fracture involve paranasal sinuses. Damage to cranial nerve to other surrounding structures, embolism, marrow, bone marrow, fat. Leakage of CSF and brain tissue from nosa if dura and nasal mucosa are torn. Infection. Leptomeningitis due to infection passing upward from nosa, shock, tonsillar herniation, fracture reaches foramen magnum. Cerebellar contusion, cerebellar edema and tonsillar herniation. Next is facial fractures. Of the 22 bones of the craniofacial skeleton, 8 from a cranium, 14 from face. 2 maxilla, lacrimal bone, zygomas, maxilla, zygomas. 2 lacrimal bone, 2 palatine bone, 2 inferior nasal conga terminate and vomer. Causes: motor vehicle collisions, falls, assault. Classification of facial fractures. French Army surgeon René Leforte classified all facial fracture into 3 types. Leforte 1. Horizontal fracture of the maxilla immediately above the teeth and the palate. Leforte 2. Fracture pyramidal, extend more superiorly through the infraorbital rim and over the nasal bone, resulting from blow to the lower and mid maxilla. Leforte 3. Transverse, also called a craniofacial separation of maxilla and naso-orbitoethmoid complex, and zygomas from the canal. Most severe maxillofacial injury results from impact to the nasal bridge or upper maxilla. According to the relationship with the impact, Cooper fractures, counter Cooper fractures. Cooper fractures occur at the site of impact. Counter Cooper occurs opposite to the site of the force. Mechanism usually occur when head is not supported. Sudden disturbances of the fluid brain content transmit force received to the opposite side. Cranial vault opposite to the site of trauma gets fractured. Circumstances of the fracture of the skull. Accidental. Most fractures are in this category of vehicular accident falls. Homicidal less common, caused by heavy blunt weapon, lathi, cricket bat, hockey stick. Distinguishing features: multiple localized depressed. Suicidal less common, seen in insane, hitting head against the wall, driving a nail into the skull. Distinguishing features: generally located closer to the head, close to the top of the head in midline. Aging of the skull fractures. Healing occurs without formation of a skull callus. To development of an external callus delayed due to damage to periosteal by age 1 week, edge of the fissured fracture stick together, 2 week edge slightly eroded. Inner table of skull shows a pitting and a deposition of the lime salt. 3 to 5 weeks, edge becomes slightly smooth. Bands of osseous tissues run across a fissure. 3 months, complete healing occurs if there is much loss of bone. The defect is filled with fibrous tissue. Differential diagnosis: Mendoza's suture. Next is mandibular fracture. The frequency of fractures of different parts of the mandible in ordering are condyle 36%, body 21% angle, 20 parasymphyal, 14% alveolar, Ramus 3% coronoid symphysis, Gertzmann fracture. Fracture of mandibular symphysis of both mandibular contact refers to the Kuhn girls who were obliged to stand still in a position of attention. If they fainted on parade, eventually they fell forward, and the first point of contact with the ground was the point of the chin. This resulted in a direct fracture of the symphysis and indirect fracture of the condyles. Thank you.